On our Health Talk series today, our special guest is Dr. Chaitanya Mudgal. He is orthopedic surgeon at Mass General Hospital. We are very happy to host him here today in our studio, and we are going to talk to him about the fingers, hand, wrist, carpal tunnel, and everything else related with this important organ of our body. This topic becomes even more relevant today because of all the new gadgets which we use these days, from smartphone, iPads, and computers, keyboards, and what impact they have on our hand as well. So, Dr. Mudgal, welcome to our studio.
Thank you very much.
And thank you very much for coming to.
It's an honor. It's an honor.
Great. So let us jump right away into our discussion. If you can first give us an overview about how, well, let's get right away into how the technology is changing the functioning of the hand and fingers.
So if you look back to the earliest origins of the hand that we know of, some of the earliest discoveries that we know go back to Lucy. Lucy was the skeleton discovered in Africa, and if you look back at Lucy's hands, you realize that some of the earliest findings in Lucy are what we can see in our hands. So over millions of years, some of the features have changed, but they're more or less adapted to what we use in our hand today. So the hand changed very much when our forefathers were hunter-gatherers. And then as we started using the hand for throwing, and we started using the hand for clubbing, the hand evolved. And so much so that we developed a thumb, and a thumb became much more a useful organ, so much so that without a thumb now, it's very difficult to function. And if you notice, the gadgets today are geared to using your thumbs. So example, your smartphone when you're texting,
Right.
you're using your thumb.
Sure.
And so that's how hands evolved, and everything we do involves use of the thumb. So not having a thumb can be a big problem. If you look at some of the other gadgetry that we use today, for example, some keyboards. Keyboards are largely set up to be used in the pronated position, i.e. with your palms facing down. So you could almost go on to say that we live in a pronated world. This function, which is called supination, is almost never required unless you're taking change in a drive-through.
Sure.
So we live in a pronated world, and that becomes critical to be able to keep your hands flat to use keyboards. Our fathers, your father, my father, used to use the old Remington typewriters,
Sure.
which were really heavy. But yet, you never heard them complaining as much as people do now of the use of keyboards. So there's a little bit of disconnect. Heavier keyboards or heavier typewriters, not much complaint. Softer keyboards, touchpads, but yet you find a lot of people complaining. So where is the disconnect, is what we ask ourselves.
So can you answer that?
Well,
Or guess?
I think if you look at it critically, and you analyze the data critically, there is really no causal relationship that we've been able to establish between keyboard use, hand pains, forearm pains, and carpal tunnel syndrome. There's really very, very little scientific data. But what may be different from your father's generation and my father's generation is that the number of people who could afford a typewriter, as opposed to the number of people who can afford a keyboard now, is so different. And that's why it appears that we may be hearing more about the association between keyboard use and symptoms. But scientifically, have we proven it? No, not yet.
So what are the early symptoms of, like carpal syndrome and the other signs of dysfunction in the hand?
So let's look at it from a perspective of, we can talk about it two ways. One, let's talk about the hand across age spectrum, and then we'll talk about the hand in the older spectrum, which I'm gradually entering.
Okay.
So if you look across ages, carpal tunnel syndrome can occur in two age groups. It occurs predominantly in people over the age of 35. So essentially it's an age-related problem. It's the price we pay for getting older. Everyone doesn't get it. Women seem to get it more than men do.
Do you have any number, like what percentage people?
So women are affected by and large, depending on the data you read, between 3 and 5 times more than men.
Okay.
And carpal tunnel syndrome doesn't happen to everyone. Again, depending on the data you read, about 7 out of every 10,000 humans are affected by carpal tunnel syndrome. And if you look at the prevalence, it is about 3.75 or 3.8% in the United States. So it's not exactly common, but it has received a lot of attention. So that being said, that's the carpal tunnel syndrome that we see as we get older. There is another subgroup which gets carpal tunnel syndrome.
Now, before we go to the other subgroup,
Yes.
my question is, why do you think there is so much difference between men and women?
We think that it's related to two possibilities. Again, it's not proven, although one of them has been. The carpal tunnel is a tunnel right about this level, starting here and going up to here. It's about 1.5 inches long, and it's bony on 3 sides, and it has a soft tissue band on one side, and in that space are running 9 tendons and 1 nerve. What we do know is that women by and large tend to have smaller tunnels.
Okay.
So we think that may be a contributory factor. And the other thing that we haven't quite proven is whether there's a hormonal influence, but we don't know that yet. So that's what happens as we get older. Now, if you look at this as a container, and the tendons and nerve as the contents, anything that gives you container content discrepancy will give you symptoms. In effect, raising the pressure within the carpal tunnel and putting pressure on the nerve, which is called the median nerve. So, reducing the size of the tunnel. So suppose you had a fracture which was badly healed, or as you get older, let's say your tendons swell due to a condition such as rheumatoid arthritis, or if you develop something like amyloidosis, then the contents have no space to go anywhere. Tendons are forgiving, nerves are not. The nerve takes the hit, and you get carpal tunnel syndrome symptoms. That being said, most circumstances of carpal tunnel syndrome are what we call idiopathic. Idiopathic means no known cause, and the only relationship that we know is age. So that's why we say it's an age-related problem.
And the second group we were talking about?
The second group is I think a little more interesting in many ways, because it really fits into the container content discrepancy model, if you want. Pregnant women. So oftentimes you will see women complaining of symptoms of carpal tunnel syndrome in the 2nd or 3rd trimester. In my experience, it is usually the first pregnancy, and usually in women who put on more than 25 or 30 pounds. They retain a lot of fluid, again hormonal influence, and it is not surprising that the nerve takes the hit because of swelling of the structures within the carpal tunnel. The good news for pregnant women is that 9 out of 10 times after delivery, when there's weight reduction and fluid reduction, within 6 weeks, 9 out of 10 women will resolve their symptoms spontaneously. And out of the remaining, most of them will also resolve it within a year. If the symptoms do not resolve after a year, then that's a problem.
Okay. Now, coming back to the symptoms. So, we have heard also is that those who are not familiar with the medicine word, medical word, is that sometimes depending on how you use the keyboard, and too much use of keyboard can also have impact on the hand and the fingers.
Right.
How much truth into is that, and what are the symptoms we should look for that before we get it?
So let's go back into keyboard use. The epidemic of association of keyboard use and symptoms of carpal tunnel syndrome is largely associated with one study that came out of Australia in the late 80s. And the Australian government largely realized as time went by that that study was flawed, and that theory got debunked. So keyboard use, it seems to us that if you do too much, you should have something going on. But our tendons and nerves are very resilient. You may feel a sense of cramping, you may feel a sense of pain and aching, usually because your ergonomics are not right. It's not because you're developing carpal tunnel syndrome due to work. So that theory no longer holds water.
Okay.
Now, by the same token, when people do get symptoms of carpal tunnel syndrome, which is age-related, they usually complain of few things. The most common thing is tingling and numbness. or in Hindi as we say, हाथ में झुनझुनी आती है. And it's usually these 3 fingers and 1/2 of this finger, largely sparing the pinky. That is the most common variety. However, there are some patients who may have symptoms in other parts of their arm also, and those are uncommon. But it is the job of the physician to tease that out. But most patients will complain of classic symptoms, 3.5 fingers, going tingly and numb, symptoms that wake you up in the middle of the night, and patients shake their hand to make it feel better. Some patients tell me they like to run cold water on it. Other patients will hang it over the edge of their bed, or they even raise their arm up, something to make the symptoms go away, and it wakes them up from their night. In the early stages, these symptoms are intermittent, so they'll come one day, they'll go away. Then as the process goes on unchecked, these symptoms go on increasing. So the frequency increases, the intensity increases, and some point the intermittent becomes constant.
So what is the time frame since the symptoms start and by the time you develop full-blown disease?
That is an excellent question. We really don't have a time frame. So some patients will come to you and say, well, I had symptoms when I had my 3rd child, and that child is 18 years old. For the last 18 years I had no symptoms, and now I have symptoms. And so, in a way, if you had to predict who will get ongoing symptoms and who won't, it's immensely difficult. We really don't have any guidelines or timeline. But what we do know is that once you have symptoms and they become consistent, then the process is almost always progressive. So, if you had transient symptoms when you're pregnant and they went away as soon as you delivered, and you may never get it again. But let's say you didn't get your symptoms during pregnancy, but you got them at the age of 45, and now you're 56, and they're still there. That is a progressive process, and that's not going to go away. So once you reach that stage, you know it's become that.
So what is the cure? What is to minimize the pain?
So in the earlier stages, what most physicians would do is, let's say you come with intermittent symptoms, they might try you with splints. Splints are basically something you wear around the wrist, and it keeps your wrists in the straight position, which we call neutral, and they largely encourage you to wear at night. They may ask you to have your workplace ergonomically assessed, and that is something that we do. Again, the scientific data to support that is very sketchy. So we really don't have good scientific data, but that's something you can control. Instead of working like this or like this on your keyboard, well, make sure you adjust the height of your chair. Make sure you keep your forearm supported. Make sure you have a wrist pad so that your wrist is not bent either way. And if you can, maybe take a break every hour or so. Those are simple things, and wear the splint at night. That's the first step. If your symptoms become more, then some physicians might even recommend giving you an injection of cortisone. I personally don't believe in it, because to me, cortisone, which is an anti-inflammatory.
And how often that injection has to be?
Well, so if you give an injection, the data to support the use of an injection is very minimal. And that data has not been replicated. There's one study which is always quoted, and that study has not been replicated by others. So you have to question data like that. That's number one. Number two, let's say you had an injection. Some physicians use that as a prognostic indicator, which means, let's say I gave you an injection and you felt great, then they think that doing an operation on you will benefit you. Again, if you look back, I'm very data driven, as you can tell. The data to support that is very minimal. But it's not a bad test to do.
Sure.
However, the reason I personally don't like using injections is because to me it doesn't make scientific sense. Number one, using an anti-inflammatory to treat a compressive problem. And number two, the anatomy here, where you introduce a needle with steroid, can be very unpredictable. We've had 3 recent studies in the last 10 years which have looked at where the median nerve is in relationship to the carpal tunnel. And in the old days we had guidelines that if you put the needle here, you'll be safe. And we realized it's not so. Which means the safe zone, as we call it, to put the needle in and give the cortisone shot is very small. And if by chance it doesn't go right, now you got a bigger problem.
Mm.
So that's another reason why I don't use it. And the benefit from an injection in most circumstances is less than 6 to 9 months.
Mm-hmm.
So to me, it doesn't make sense.
Sure.
And that's painful.
Yeah.
You know, sticking a needle into someone and giving them a bolus of cortisone right into this area can be quite painful. So I see no reason to inflict unnecessary pain.
So, what are the other, like, symptoms or other problems which can happen with the fingers and hand?
So the commonest that we see in people are carpal tunnel syndrome, as we talked about.
Sure.
The second most common thing that we see as we see aging people is trigger fingers.
What is trigger fingers like?
Trigger finger, again, is a condition that's commonly seen as we age. And it is usually associated with a clicking and your finger gets stuck in the bent position. And then either you pop it open by yourself, or if the condition progresses, you have to use your other hand to pop it open. And if it progresses even further, then you can't even close your finger. And usually,
how common is this? Like?
Extremely common. I'll give you an example. If I were to see a day full of patients, I would expect to see at least 5 to 7 patients every day with trigger finger. So I would say, on any given day, you could expect to see between 5 and 10 patients easily who come to you with that. And the age range varies from 35 to wherever. So it's again, older population. But the difference being, the possibility of you developing triggers goes up big time, almost 5 to 7 times if you're a diabetic. Goes up even further if you're type 1 diabetic, and goes up even further if your A1C levels are not well controlled. So there's an increasing frequency. Now, why does that happen? Why do people get trigger fingers? Well, we think that the tendons which bend your fingers here, they get stuck in little tunnels right about there. And that's why you tend to be sore, and as you bend your finger, the tendon gets stuck, they get pain here, and when they pop it open, it's exquisitely painful. That's why patients come to you. It's not so much so the physical inconvenience of a clicky finger,
Sure.
it's the pain that it causes.
And is there any like surgery or anything cure for that or no?
So this trigger finger, if you look at trigger fingers come in 6 different types. I'm not going to tell you about all
Sure.
of them, but early stages, if patients come to you within the first 2 or 3 months and they're non-diabetic, then you can actually treat them with a small splint that they wear at night. And the success rate of that splinting, we just looked at my own data, is about 53%, which is not bad. You wear it only at night, it's a small splint, doesn't disturb you, and 53% of the time you're going to get better. Now, how durable will that benefit be? We don't know. So let's say that's one group. But if you come with symptoms of more than 2 or 3 months, then the next step is to give you a cortisone injection. Success rates of those are very high, anywhere from, depending on the data you read, from 70 to 85%.
That's very good.
That's very good. The durability is unclear. So patients who are non-diabetic may have one injection and be done. They may feel great and never come back to you again.
So now we covered the trigger finger and the carpal syndrome. Is there any difference in the Caucasian population and the Indian or Asian population, or not really?
Well, to the best of my knowledge, I don't think we have clear data on Indians by themselves. I can tell you I practiced orthopedic surgery in India for about 5 years. And I honestly saw very little carpal tunnel syndrome. But that may be because in those days, and I'm going back to the early to mid 80s, we were not as sophisticated in our diagnosis. And patients probably just did not feel that it was important enough to come to you. So I'm not saying, I don't think I'll go so far as to say it's not common. I just don't think we did a good job diagnosing it. But that being said, how many Indian patients do I see of Indian origin for carpal tunnel syndrome? Very few.
Now, what about the nerves and all in the fingers? How do they get impacted somehow?
So nerves in the fingers get impacted not because of local conditions. They get impacted as a resultant of pressure on the nerve in carpal tunnel syndrome, which gives you numbness in your fingers, or pressure on another nerve called the ulnar nerve, and the condition is called cubital tunnel syndrome, which gives you numbness in these 1.5 fingers. So that's how the nerves commonly get impressed.
Now, also, at least I used to see in my my village in India is that we had a couple of people, they will be always shaking their hand, always, like this. Is something related with that, or it has to do with nervous system?
Now, so it sounds to me like you're describing tremor.
Like all the time they could not keep the hand still.
So that, hand tremors or involuntary movements are so multifactorial. I think that they would be beyond the purview of this discussion of ours.
Sure, okay.
But most commonly, if you see patients who have tremor in an elderly person, it can be something that we call either essential tremor, a familial tremor, and that is part, again, it runs in families, or it can be activity associated tremor where you're reaching for a cup and your hand starts shaking, commonly seen in the elderly. And when they're not reaching for the cup, the hand doesn't shake. And then there, of course, Parkinson's, which is very commonly seen in the aging population. But those are distinctive conditions, and they are usually accompanied by other features. So if you had to have seen those, the best thing to do is speak to a doctor and seek counsel from a neurologist. So.
Now, so if we take all these things we talked about, is there any precautions we can take, or we can do certain things to avoid these things happening when we age?
So, the thing is, the hand, I like to quote Sterling Bunnell. Sterling Bunnell is considered largely the father of modern American hand surgery. And he used to say, the hand is like a bird. If caged too long, it may never fly again. What that means is, hands are not meant to sit still. Okay? Hands are meant to be used. Hands are meant to be moved. The joints are meant to be moved. So anytime, I see people all the time who will come in with a small injury, but their hand is extremely stiff. And the reason only being they didn't use it. So the adage, if you don't use it, you lose it, is very common to the hand, is very important to the hand. So if you want to maintain hand function, simple use of the hand on a regular basis is just good enough. The hand is very forgiving. Just because you have terrible arthritis and your fingers may look deformed doesn't mean the hand has to be kept still. It doesn't mean that you can't use the hand. The hand will still work very well.
So, and what type of arthritis we can have, like, here or wrist or fingers?
So most commonly, arthritic changes in the hands happen to all of us. It's the price.
What do you mean happen to all of us?
It's the price we pay for getting old.
Okay.
What is arthritis? Arthritis is a condition where the joints that are there all over our body consist of two bones, most of the time, covered by a layer of cartilage. And the cartilage is so smooth that it is like ice on ice. If you took one ice cube and ran it on another ice cube, 1/10 that friction, 1/10 is how smooth our joints are. So there's no friction there. If that cartilage wears out, then the joints become rough.
So what are the chances of that cartilage on average wearing out?
Very common.
Like what percentage?
I would say as we get older, I would say everyone gets it.
Okay.
But everyone doesn't get symptoms.
Okay.
Okay? So cartilage that we have in joints is not destined to stay the same at age 85 as it was when you were 12. There is going to be wear and tear, there's going to be breakdown. It's like a washer in your tap, or a fan belt in your car. Too many revs, then it's going to give out. But everyone doesn't get symptoms, and that's the beauty of the human body. But when they do get symptoms, they get them in predictable areas. So for example, women largely get arthritic changes in the tip knuckles and at the base of the thumb. That is a female pattern of disease. Men, on the other hand, occasionally, not only do they get that and this, but they can also get the joint right next to the base of the thumb, which is typically male. And these joints are largely spared of arthritis. But when they do become arthritic, they do so in men. So female and male patterns are very different. And at what age can it start? Well, some people who have a strong family history, it may start as early as 40 or even slightly earlier. And in some patients, they'll tell you, my grandmother had the most gnarly knuckles and my joints look funny, but they don't hurt. So that's another beauty. Your knuckles may look funny, they may look ugly, but they may not hurt.
Now, this is the truly fun thing here. When we were kids, and growing up in India, And some kids will always, that like
Pop their knuckles.
Knuckles, Is that dangerous or what
No.
is that thing?
So that is a very commonly asked question in my office.
Okay.
Patients will ask it all the time. If I crack my knuckles, am I going to get more arthritis?
Right.
No.
No, so it's just we can crack it as many times as we want.
It's a good party trick,
Okay.
but it's not going to do you any harm. We really don't know why it happens. We have some theories about it, but it's not going to make your joints wear out any faster.
What about any special type of food, any nutrition which are valuable to these things? You can talk about that, or it doesn't matter much.
So, if you look at it from a protective effect, we really don't have any foods that stop you from getting arthritis. There's no way to stop it. There are substances that we encourage, that have been encouraged by some people, that they are supposed to be joint protective, like chondroitin, which you can buy in the store, and you can take it in the pill form. Again, no data to support it.
Sure.
The beauty is, it doesn't hurt you, and some patients swear by it. Now, is that real or is that placebo? I don't know. If it doesn't hurt you and you can afford it, go for it.
Yeah. So now one question for you is, how did you get interested in hand and wrist and all? Of all those so many disciplines?
So, when I started off, I trained as an orthopedic surgeon in India. And there's a point in time where I really wanted to do children's surgery, children's orthopedic surgery. And I soon realized that I had difficult time seeing children suffer. And I was much younger then. Now I take care of children all the time. But in those days I found it very difficult. And then I found I was being drawn to minutiae. And the more smaller and the more intricate it was, I found it appealing. And the beauty of hand surgery is you get to sit down and operate. And I like to sit and operate.
Yeah, okay.
So, but it's the minutiae. I'm very detail driven, and the detail in the hand is second to no other human body part.
Excellent.
So,
Roughly how many surgeries a day you do?
I operate usually about 1.5 to 2 days a week, and anywhere per week it'll be between 8 to 14 surgical procedures. But they are not, when we say surgical procedures, I don't want anyone to get the misconception that they are all large procedures. Of course, for each patient that procedure is big.
Sure.
But doing a trigger finger release is really, it's about a 15-minute operation. Doing a carpal tunnel release is about a 22-minute operation. So you could do many of those, and their numbers may seem high, but realistically they are very small but very effective procedures.
So now concluding the interview, what are the 5 things or 5 points you will say to our viewers that we should look for, watch, or do?
So I would split them up into things to watch out for as you get older, things to watch out for when you're doing recreational activity, and things to watch out for when you're doing household and yard work kind of activity. So let's start off with things to do as you get older. Keep your hands mobile, keep them well moisturized, don't let them get dry and cracked. And when you have your manicures, please be careful you don't push your cuticle back too much. In terms of recreational activity, please be careful when you are playing ball sports, because ball sports are one of the leading causes of finger fractures, especially volleyball and basketball, where you're not guarded and the ball is coming at you at speed and you can get injuries. Of course, it can happen in any sport.
Sure.
And finally, when it comes to using activities or appliances around the house, you have to be extremely careful when you're using skill saws and table saws. You have to be extremely careful when you're using snow blowers. Please, 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 please do not stick your hand down a snowblower chute. If you forget everything I've told you today, please remember that. Do not stick your hand down a snowblower chute. I see people who destroy their hands every winter when they try to unclog a snowblower chute. And finally, when you're cutting a fruit, when you're pitting an avocado, please don't do it in your palm. Set it on a firm surface and cut away from yourself. And the last common injury that I see is when people are cleaning glasses. when they're drying glasses. They hold the glass and they try to get to the bottom of it and dry it. And that's one way of cracking the glass and cutting your palm and cutting your tendons and nerves. So these are common things that I see all the time. I could go on forever,
Yeah.
but these are the common things that
Well, this leads to me another question for you. What has been one of the craziest victim you have seen with a hand, or which you think that was very unique or crazy?
Well, most hand injuries come out of unique circumstances. They are usually unfortunate circumstances. And some of the things that really
Anything you remember?
is when I mean, obviously I can't tell you more specifics because of patient confidentiality.
Sure, yeah, but without giving the name.
But you know, when you see someone who's young, who plays with, say, firecrackers, and in India we used to do it all the time.
Sure.
Light a firecracker and hold it till the last second and throw it.
Yeah.
And you miscalculate. It blows your hand off.
Mm.
And having seen that innumerable times around July 4th, I would say to kids, please don't play with firecrackers in your hand.
Right, okay. Excellent.
They're unforgiving.
Excellent. Well, Dr. Mudgal, thank you very much.
Thank you very much.
We are looking forward to your speech at the Health Expo.
I'd love to do it. I'm
And,
looking forward to it myself.
Yes, yeah, it's going to be a great event, and see you then.
Thank you very much.
Okay.
It was wonderful.
Thank you.